carcinoma.
Nasopharyngeal carcinoma.
So I don't know whether there's a link between the malignancy brought on. She received chemotherapy.
She had 7 years after.
So 7 years after. So at the age of 18, she had the cancer.
And may I ask, where are you from originally?
Originally, I'm from India.
Where in India?
Hyderabad. South of India.
Very strange.
Yeah, but from Los Angeles.
Yeah.
So,
Skin cancer.
Skin cancer.
About 3 years after being diagnosed.
3 years after diagnosis. What kind of skin cancer? Melanoma? No. Not melanoma. Okay. Non-melanoma.
Skin cancer too.
Non-melanoma?
Non-melanoma.
How many years after or before?
I've had both before and after.
Before and after.
Skin cancer.
Anyone else? Any? Yes. Okay. All right. Well, glad that you guys are here. Yes.
I'm a lot of skin cancer before and after.
Okay. Well, what I'm going to basal cells. Okay. So what I'm going to do basically is I'm going to start with a certain topic and we're going to keep it interactive. Okay. What I've learned doing this previously, that the slides doesn't work that well. This interaction is what works much better for me at least. Okay, so first of all, I'll start with what is cancer-associated myositis, right? I mean, that's the biggest challenge that we have. To be honest, it essentially means that there's some association in time. Means within a year of cancer, then you're very sure that the cancer is associated with dermatomyositis. When you go up to 3 years, we still have a certain confidence that the cancer-associated dermatomyositis still, or myositis still exists. Up to 5 years, there has been shown association. After 5 years, what has been shown is the rates of cancer in dermatomyositis and polymyositis are the same rates of cancer as if you don't have dermatomyositis or polymyositis. So we don't know if people who have gotten cancer after or before 5 years, is there a link or not? There could still be a link, and I think there may be there's a reason to believe there may be a link. For example, nasopharyngeal cancer is linked with dermatomyositis. It's not a very common cancer, and if that cancer is very tightly linked with dermatomyositis in Asian population, mostly Chinese, Japanese, Southeast Asian, not seen much from India. That's why I was a little surprised. But that cancer is tightly linked with dermatomyositis, and that's why I think in your case, even 7 years, there might be some reason that it actually brought on. So that's the definition we use. Some people use 3 years definition, before and after. Some people use 5 year definition. But the strongest association is if it's within a year. Okay? And most cases that we see cancer-associated dermatomyositis or polymyositis is within a year. Then we see a little bit less in 3 years and we'll see a little bit less in 5 years. Okay? So that's the definition we use. What is more common? Is it dermatomyositis or polymyositis for cancer association? Does anyone know? Yes. Dermatomyositis, previously we used to say 30%, up to 30% of dermatomyositis can have cancer. I would say that number is a little exaggerated because we don't see it that often nowadays. Okay, so I think the real number to me is about 15 to 20%. Okay, but for polymyositis, it's half the risk. So I say 5 to 10% for polymyositis, and I say 15 to 20% for dermatomyositis. Okay. Is anyone in the room has necrotizing myopathy or immune-mediated necrotizing myopathy? No. Okay. Well, we don't need to talk about that. That's an entity where you have a very bad disease, and it's called necrotizing myopathy. In that entity, there is also some signal that is increased risk of cancer, but not as much as for poly and dermato. So there's some signal there. We don't need to go there. Okay. So we talked about how is it called, what's more common, what are the risk factors? So if I see somebody with dermatomyositis or polymyositis, how does a physician think of that patient may have a high risk or a low risk or a moderate risk? Does anybody?
Family history?
Family history, excellent. So the answer is previous history, family history or previous history of cancer. So if somebody has previous history of cancer and they develop dermatomyositis, I'm very worried because I want to make sure that that cancer is not coming back, first of all, because the cancer can recur, so you have to think about that. So family history or previous history of cancer, what else?
Antibodies?
Antibodies are very important in risk assessment, okay? And that's where the power of antibodies, I think, is really strong for cancer-associated myositis. So what antibody are we talking about? There are few antibodies that I'll talk about. So first of all is an antibody called TIF1 gamma antibody. Has anybody heard of that? TIF1 gamma is like this kind of sign. But TIF1, if you remember, is good enough. Anyone, the people who told me they have had cancer, anyone of none of them know that they have TIF1 antibody? No, none of them have. Have you been checked for antibody?
No. Yeah.
Yes,
I have TIF1, no cancer.
You have TIF1, no cancer.
5 years
Excellent.
out.
Excellent. 5 years out.
Another TIF1, no cancer.
No cancer. Perfect. So, okay. Now, here's what my personal research has shown me. TIF1 does not necessarily cause cancer. A lot of time, there's some misinformation that people believe that if you have TIF1, oh my God, you've got a cancer. That's not true. The reason it's not true, we see TIF1 very commonly in kids, and there is no cancer there. So this notion that it's definitely going to cause cancer is not true. And there are patients who are, what I would say, how old are you dear? How old are you?
54.
54. How old are you?
42.
42. Younger age group, TIF1 gamma, less cancer. Okay? Higher age group, plus 60 for sure, much higher risk for cancer. Okay?
Is that
So,
the onset versus when I get to 60, do I worry more?
no, you don't need to worry about it. It's the onset of the disease. Okay? If the onset of the disease is above 60 years of age, 55, 60, 50, you can make whatever cutoff you want to make. But higher the age, TIF1 has higher association with cancer. Lower the age means juvenile, there is no cancer. Okay? So keep keep that in mind. There's another antibody, and the other thing with TIF1 you have to remember, TIF1 also can cause bad skin. Especially in kids, it causes bad skin problems. Okay? The other antibody is called NXP2 antibody.
Can you say that again?
NXP2.
X.
NXP2 antibody. That antibody is not as strongly linked with cancer as TIF1, but it's the second common risk antibody with cancer. Okay? If you have that antibody, that also increases your risk of cancer significantly. Okay? Then there are protective antibodies. Which are protective antibodies? Antisynthetase syndrome antibodies, which are JO1, PL7, PL12, KS. Sure. Yeah, you don't need. So, antisynthetase antibody, which are JO1, PL7, PL12, EJ, OJ, and KS.
Okay.
KS. Okay?
So
Those.
we need to know this because we have to go and tell our doctors
Sure.
to do this.
Sure,
Because
sure,
they
fair,
don't
fair
tell
enough.
us to do this.
Fair enough. So these antibodies, if you have these antibodies, then it's generally the cancer is less frequent. I do not want to make interpretation that there is no cancer. The point is the risk is lower. In TIF1 and NXP2, risk is much higher. With this antibody, the risk is lower. I have personally seen cancer with this antibody, so don't think that the risk is gone. It's lower. Okay. All right. So those are the antibody. I saw two questions. Yes.
One question. So when you're diagnosed with DM, do they automatically test you for these things? Should you
Excellent
assume that they
question.
have?
Excellent question. I'm going to answer that. Yes.
My question was similar, and
Okay.
I was wondering, like, if I requested them to test my husband for MDA5, and he tested highly positive for that, but do they still need to test for others? Could he have more than one?
Two good, very good questions. Okay, I'm going to take your question. So your question was, what do I need to tell my physician to test for these antibodies or not? That was your question, right?
Well, I was diagnosed with DM, so does this doctor know?
So
to
does the
go-
doctor
is this
know
like a full
automatically?
panel of things?
No, that is
No.
not true. Because think about this way, rheumatology training has a lot of different diseases. And how many patients does a rheumatologist during their training see of dermatomyositis and poly? You can count a number of in your hand.
2, 3, 4.
So 3, 4, maybe 5, maybe 10. Very lucky that they're 10, right? So their training in dermatomyositis, polymyositis, IBM is very minimal. Their reading could be a lot better or lower, depends on what they have done. So it's very variable about the knowledge that a rheumatologist would have about this disease, and then for antibodies, there's more newer research coming up. So they may not have read upon it.
But you're assuming that I went to a rheumatologist, I did not go to a rheumatologist, I went to a dermatologist.
Dermatologist, the same. And neurologist, the same. Remember, they're reading about this topic. This is a rare disease. So how much attention or time or devotion they're going to put on this disease in their training is pretty low. And a lot of these antibodies are upcoming and new. So if they're the older physicians who are not really keeping up to date, they may not know this. And remember, they might be reading a lot, but this is a rare disease. That's not their area to read every day. If they're going to see only few patients in a year, they're not going to read about it. So that's why, as a patient, you need to be a little bit more upfront and educated and talk to your patient and talk to your doctor about it to check these antibodies. The other thing is, you may not know that your doctor might have checked you for it.
Right.
Because that's another problem that we see. A lot of doctors know about it, they send a panel, they check everything, but they may not necessarily talk to you about it. Because how many things they're going to talk to you about. So the doctors have this tendency of talking about positive things. Means the things that came out abnormal in your blood work, or something which was very significantly negative. They don't necessarily go into each and every detail if it wasn't relevant to you in your case, for example. Okay, so that's to answer your question. So if you get newly diagnosed dermatomyositis, you should talk to your doctors about doing these antibodies. Definitely, they have much fun. And if they do it and they're positive, your doctor knows how to read it and can help you. So that's an easy part. The issue is to do it. And I think I'm forgetting your question. I forgot. What was your question there?
My question was if I had to specifically ask a doctor
Yes.
to test him for something, could he have other
Yes.
antibodies?
So the question is, if you have one antibody, could you have more than one antibody and have that risk? Generally, no. These antibodies are generally mutually exclusive. Means if you have one antibody, then you're likely to have that antibody. The overlap of two antibodies in like 1 or 2 or 3%. So it's very rare. I mean, I've seen it, but it's rare. Then if somebody has an antibody, I just quit there. Okay, I'm not going to test you more. I already got my positive antibody. Okay, so that's there. There was a question here.
Yes, so I see a dermatologist and a rheumatologist. Which one did it ask doctor for me to ask for this test?
Rheumatologist. For autoantibodies, a rheumatologist, because rheumatologists are better trained in knowing and interpreting these antibodies in our training overall. Yes.
Is it more than one test, or is it?
That's a good question. So the question is, how do we test for it? That's the basic question, right? I mean, so the problem is, there is no standardization of this test. Okay, that means if I order rheumatoid factor in rheumatoid arthritis, I know if it's positive or negative. This result I can trust because I can do it in any lab. I do it in any lab. I know it's positive or negative, and I'll get results. In this case, that's not true. First of all, every panel is different, and every panel's utility or specificity and sensitivity is different. So I cannot tell you to do this panel and you're done. I can tell you which are better panel and less better panel. There's a panel called Myomarker 3, Myomarker 3. Myomarker 3 done through RDL lab in California, which has most sort of antibodies I've seen. Okay. The other lab that I like is called OMRF. OMRF. It's an Oklahoma research lab where your doctor can send the sample and they can get these antibodies tested. It's generally the OMRF takes about $200 to $300 for the test, and RDL lab, I forgot how much is the charges, but like around $200, $300, or $400 for the whole panel. Yeah, and it's less than $500 for sure for the whole panel. So and then there are other labs, for example, Quest. So if you ask Quest to do myositis panel, they will do certain set of antibodies, but they will not do HMG coenzyme A antibody. They will not do MDF5 antibody. So each panel kind of misses 1 or 2 here and there. Last I talked to Quest, they were trying to build up the portfolio so that they can do just one test and all of them get tested, which hasn't happened yet, okay? So those are the issues that we haven't gotten a good standardization. And I must tell you, I see false positive and false negative all the time. And how do I know it's false positive and false negative? The only reason I know is we have a research lab. So we do our antibodies in our research lab as well. So if on my research lab it was negative and that it doesn't make clinical sense, okay? So how do I know clinical sense? Each antibody has a unique clinical features, okay? If that is not matching up based on the autoantibody positivity, then I'm going to question it. It still can possible because they're all variabilities. But if that doesn't match up with clinical features and it doesn't match up with my research lab, then I'm pretty sure it was false positive, okay?
Can I just ask you, in the last sentence you mentioned MD5?
MDA5 antibody, MDA.
And then there's another one just before that?
In which is not done routinely is HMGCR, anti-HMGCR antibody. And so MDA5 antibody is an antibody which is seen in dermatomyositis, and it has been associated with bad skin and severe interstitial lung disease, pulmonary fibrosis. Those are two characteristic features, okay? Whereas HMGCR antibody is linked with statin-induced autoimmune myositis. So if you have received statin and then developed weakness and then it went on, even if you stop statin, that's that antibody is associated with, okay? Yes.
If you test positive for an antibody and then after treatment it goes down to the normal, within a normal range, are you still at risk for the things associated with that antibody?
That's a great question. To be honest, we don't know exact answer to your question, but I must say that I'm always happy or relieved when I see that antibody goes down in the level. Okay, that to me it means that the antibody that was a marker of the disease has gone down. But I don't want to say that it's an absolutely safe thing. Means it's not that you're in the safe zone. It's just likelihood is that your disease won't come back or will not cause much problem. In most cases, we don't see the antibody to normalize. We see that these antibodies drop the level after treatment. But in most cases, I have not seen them to be normalized.
So
Means they don't go negative for me. For me, they go down in the level.
If they're tested at two different places, could that cause a discrepancy then? If one is highly positive, one is at a normal level?
Yeah, so the problem is that, as I told you, there's no standardization. So somebody's high, maybe somebody's low. So it's not low or high because you don't know what you're comparing apples to oranges.
Okay.
Different test. He might have done by ELISA, he might have done by a bead test.
But they did see it, so it was
If
there.
it's positive, it's positive.
And you had two.
Well, because we don't have a study. In future, hopefully, we will have that high and low and moderate and all those levels. I mean, generally, I must say false positive is a low level. Generally, whenever I've seen false positive, they're at a lower level. Means they get detected, but they tell me that it's a lower level. That's when I've seen the false positivity mostly. Okay. So, any questions? Okay, go ahead. Yes.
So if we see well, with either one, should we get a second opinion? I mean, if it's positive or false positive, should we get a second opinion?
No, if it's positive and it meets your disease criteria, means it matches up with the clinical features, generally we don't repeat it then. You know, it's just basically if it's positive and it makes sense, that's good enough. Only time I repeat if it's positive and it doesn't make sense to me. And that's when we repeat it. Yes.
Just curious, is it traditionally way of thinking is that once you remove the cancer, you remove the end?
So we go going to treatment. Okay, good.
Repeat that.
So question is there a general feeling that if we remove the cancer in cancer-associated dermatomyositis, is that a treatment for DM? Means the DM gone away. Okay. So I'll try to explain that a little bit. Okay. Well, I'll try to expand on it. Okay. So what happens is if somebody has cancer-associated dermatomyositis, let's say, means they have a cancer and their dermatomyositis active same time. Let's say for sake of simplicity, let's say same time. So what we believe is that cancer is actually providing food or providing stimulus for the dermatomyositis, okay? So that means the cancer needs to be taken out, okay? That's the primary thing that we need to do. Either it needs to be treated with radiation or chemotherapy, or be excised out, or be treated, whichever way it needs to be treated, so that that continuous stimulation that is causing immune system to ramp up and cause the dermatomyositis is gone, okay? But that's a necessary step, but may not be sufficient step. Means in most cases, we still have to treat them with immune suppressive drugs. Because now, even though the cancer might have led to it, or might have stimulated it, but now it is the autoimmune disease on its own. So you have to treat the autoimmune disease as well. But if you don't treat cancer, if you only treat autoimmune disease, it will get better, but I don't think it will be completely gone. Because you're treating it so the symptoms will get better, but it may not get resolved. So you really have to remember two things. Effective treatment of cancer and effective treatment of dermatomyositis needs to go hand in hand for patients with cancer-associated dermatomyositis. The other thing I want to expand is, what if somebody gets treated, have cancer-associated myositis, if cancer is treated and then the dermatomyositis is treated, would they go off treatment quickly because now the cancer is gone? That's not true either. The treatment of dermatomyositis should be standard, whatever I would do for a non-cancer patient, but I still need to get the cancer out, okay? The other thing that we see, what if somebody got treated, 2 years later, their dermatomyositis came back? What does that mean? That it means it is possible that the cancer may have come back or may not. Why may not? Because it's an autoimmune disease, it's a mind of its own. So immune system could have been reactivated without stimulation, but more likely that it would got reactivated because of the stimulation. So you really go after looking for the cancer.
And when you say DM goes away, let me make sure I understand the interpretation. That means I am no longer on steroids, Celsar, or any of the above. Is that what you're saying?
No.
Or are you saying DM is being inactive?
Inactive. What I mean is inactive. It's
So
inactive whether on treatment or off treatment. If it was inactive and it became active, then you got to think of, is there something else going on? Okay. Okay. So, any questions? All right. So now I'm going to go to the treatment. I'm going to keep on the treatment thing a little bit more. Okay. So let's say you treat patient with when I see patient with dermatomyositis cancer, I treat their cancer, I treat their disease as I would normally treat any dermatomyositis patient, but then I keep following them very regularly for any flare-ups of cancer. So one thing I tell them, see me, but also see your cancer specialist regularly. Do not cut down surveillance for at least 5 years. Cut down on the surveillance means you keep going to your doctor, cancer doctor, check. Let's say breast cancer. I tell them, listen, do mammogram every year. Don't skip it. And if your doctor tells you to do 6 months, 6 months is fine. But keep checking for the cancer recurrence, because in cancer treatment, earlier detection is the boom. So if your doctor is able to detect the recurrence rather quickly, that's a great way to go, okay? The other thing to remember is what treatments can be used for cancer-associated dermatomyositis when somebody is active cancer. That is very tricky. Why? Because cancer treatments are huge immune suppressive treatment. You have chemotoxic drug, and if you can't give another chemotoxic drug when somebody is getting cancer treatment with chemo, right? I can't give somebody methotrexate and Celsar when they're getting heavy-duty chemotherapy, right? So what do? What are the treatments that are recommended for cancer-associated myositis which are good with ongoing chemotherapy? Okay, that's a question that is a very important question to me. And the treatments are steroid is good because steroid doesn't cause any problem whether it needs to be chemotherapy drug. But the drug that I really like in this situation is IVIG. IVIG has no problem with your cancer, okay? It's not going to cause any more immune suppression. It's not going to cause any toxicity with your cancer. It's really the best drug to use when you have active cancer and dermatomyositis because it's a safe thing to do. So I put them on. Only problem with IVIG is IVIG increased risk of blood clots, okay? And cancer increased risk of blood clots. So you got to be worried about that part. But other than that, the other thing that IVIG can do is cause stress on the heart because it's a lot of volume. So heart needs to be in a good shape for IVIG, and a lot of chemotoxic drug can also affect heart. So you got to watch for a few things, but in general, I would say IVIG steroids is probably your best bet when you have an active cancer. Okay. Now, what about, let's back off from cancer a little bit. If you come to me with dermatomyositis, what should your doctor do apart from autoantibodies? Because autoantibodies doesn't tell us that cancer or not cancer. It tells you the risk of cancer and not cancer. Okay? So what kind of cancer screening should be done on any patient or every patient? Does anybody have any idea?
Breast, pelvis, abdomen, chest, rectal.
Perfect. Skin. Excellent. Okay. That's perfect. So what we do is normally every patient with dermatomyositis and polymyositis, more for dermato, less for poly, should undergo at least the basic screening based on age and gender based recommendation. What does that mean? Generally that means mammogram, for example, in a patient with age above 30-35, okay? Generally that would mean pelvic examination for all females, and generally would that mean colonoscopy for age above 50, okay? Would mean PSA testing for men above age 50, okay? Would mean a basic chest x-ray, okay? Would mean a normal, what we call a CBC, to look at the blood component, okay? Those are the common tests that we do on everybody who gets diagnosed with this, okay?
And throat, probably.
Throat, generally don't, unless there are symptoms. If you are living in Singapore, Hong Kong, that's the first thing you get. You get sent to ENT to look for nasopharyngeal cancer. Okay? Because the association of cancer in those countries with nasopharyngeal is very high, very, very high. Or even in this country, if I see any patient from that region, Vietnam, all of the Southeast Asian countries, I would go for that as the number one. So there are some differences in ethnic differences in what cancer can do. What if I do all of these tests? And these tests are all negative, means the cancer screening is all good. What do I do then? This becomes a little bit more tricky now. So my next step is, should I do a PET scan? Should I do a CT scan? What should I do? That is where the autoantibody or the risk helps us. Okay? If the autoantibody is TIF1 and NXP2, I'm going to do CT scans on them or PET scans on them.
Really? I'm sorry. Could you repeat that? When all the tests are negative, what would you do?
So my question is, when the basic tests are negative, these are the tests that everybody should get at a baseline. Okay? But what I'm saying is, if a basic test, these basic tests are negative, these are age-appropriate screenings are negative, how do I decide I need to do a PET scan or CT scan or go a little bit further than this? That's where the autoantibody helps me. If I see a patient with TIF1 gamma, especially age above 50, I would do PET scans on them. I would do, chest, abdomen, and pelvis CT scans and PET scans on them. Okay. The other things that can help me is, number one, is how's the patient doing? If I treat them and they start improving right away, I'm less worried about their cancer. As I told you, cancer is a needus for the disease, right? So if they start to not do well, if they're not improving on a normal regimen that most people improve, then I got to worry. Okay? Means lack of improvement on standard therapy, I worry. Second, weight loss. If they start talking about huge weight loss, if they have bad skin ulcers, necrosis, means they have very, very bad ulcerations of the skin, that has been linked with cancer as well. So if I see any of the...
What kind of cancer would that be?
It could be any of the cancer. We will talk about what kind of cancer in general, but any cancer, bad skin ulcerations have been linked with cancer, okay? Weight loss have been linked with cancer. Higher the risk of cancer, okay? Severe disease have been linked with more and more severe disease, worse it is. Non-improvement to standard medication have been linked with cancer. Males slightly more than females in terms of the risk are linked with cancer. So those are the other risks that I use to see to what extent should I go for screening. But once the screening is done, is my job as a doctor done? It's not, because this can come up. We just heard 3 years, 5 years, right? So you have to keep screening every year without symptoms, and then symptom-based screening whenever symptoms occur. Okay? So every year screening, basic screening every year without symptoms, and symptom-directed screening. Okay? If you have a symptom, then it should be looked into. You know, you should wait. You should wait or go away. You should look into it right away.
Well, what is basic was a colonoscopy, certainly for a male like me. You're saying, even though the last colonoscopy was great, should do another one in the year?
No,
You didn't say that.
I did not say that. What I'm saying is, next year, you should again look for what is age-appropriate screening recommended for you. So if you had a colonoscopy, and let's say there was no polyp, it was a clean colonoscopy, you're good for 5 to 10 years. You don't need to, you're already in that window of clean. But let's say there was a polyp that they removed. In that case, if they recommended screening back again in 2 years, you don't want to go over 2 years. You want to next 2 years get the screening done again. Okay. For example, mammogram is every year. You know, pap smear might be every year. It depends on the risk factors. Blood counts, chest X-rays. These are normal things. The other thing I recommend in terms of screening is pelvic ultrasound to younger females if they have a high risk of cancer, based on what are the things that I've told you. You know, right
3
antibody.
years for that? 3 years for that?
3 years for that. Well, at baseline for sure, and then if the patient continues to be high risk, then yes. But if the patient is not a high risk, means a patient scenario, I'll give you at baseline, I'll do ultrasound, and the patient is clean, I treat them, and the disease is in remission. Then I'm not going to worry. Next year I may just look at it because the disease is so good that probably they don't have an underlying cancer. Does that make sense?
When you said there was a polyp and a colonoscopy, you know, you would do it again yearly. Endoscopy, same thing?
So endoscopy is not a normal basic screening. So only if somebody is having trouble with food, symptoms, weight loss, I would do endoscopy.
So I actually had that done for those reasons, and I did have some multiple polyps removed. So would you want to do that again in a year?
So my question to you, doctor, was this polyp completely benign, or was there any suspicion and they wanted to repeat it in 2 years or 3 years? I would follow the recommendation based on what was the polyp look like. You know, was it like a regular polyp, or was it a little bit suspicious polyp? Was it a completely benign on the biopsy or not? And based on that, your doctor can tell you that your next screening should be 2 years, 3 years, 5 years.
Thank you.
Pap smears for women over 70, I've been told, is not age recommended.
Absolutely right. Absolutely right. So I would. So pap smear above age 70 has been not recommended. We're talking about normal general population. We are talking about here is higher risk of cancer, right? With high risk of cancer, it still might be worth it. Okay.
You know, when I had the melanoma, now my dermatologist, I have to go there every 4 months for full body screening. Every 4 months, and it's still there.
That's great. The other thing is skin cancer is often neglected and is not looked at, which can be a major problem. So when the patient gets first diagnosed, and especially if they are high risk, they should get a dermatology appointment and good look at the skin. Yeah, so that would have been difficult anyways. That would have been a pretty bad situation, to be honest. But in general, at least one visit to a dermatologist for screening of cancer in a patient who is high risk. We only do it for high risk. We don't do it for a lower risk. We only do it for high risk, like type 1 gamma antibody, somebody with bad skin ulceration that is not getting better. You know, those kind of situations we recommend.
How often? How often at that point?
Generally, it's once a year. See, again, it depends on is the risk continuing or not.
Freckles, they're gonna want to see.
Exactly. Is the risk continuing? So the follow-up cancer screening is based on the risk at 1 year. It's not based on your original risk. Also based on how are you doing right now. Is also that also factors in. Yes.
Is there any study as far as the probability that a patient will get cancer again if they have more than 2 years?
So would they get a cancer again? That's what I was trying to say, that yes, that can happen. That cancer can recur. That's why if you have had cancer, you'll be very vigilant to keep checking it. so it doesn't come back, because we've seen the cases where it can come back. Yeah. Yes.
Just going back to one of the treatment options that you mentioned for myositis, dermatomyositis, the IVIG treatment, is that, I know I've spoken to a lot of different patients and they've been on it for multiple years, several years. Is that something that is, in your estimation, a long-term treatment? Are there any alternatives
So
if that
I think what I was
fails?
trying to say is, if you have active cancer, what would be the best treatment?
Right.
But once the cancer is taken care of, you can go on any treatment that is recommended for general population. Okay, except there's few exceptions. For example, somebody with breast cancer may not want to go on methotrexate. That has a little higher risk of causing cancer. So there are some of those, but you can go. You don't need to stay on IVIG once the cancer is gone. It's just that during the cancer treatment, IVIG might be your best bet. But once the cancer is gone, you can transition into any other treatment based on the cancer and the risk. Does that answer your question or no?
I was actually looking, referring more to the diagnosis of the myositis.
Mm-hmm.
So once cancer is in remission for several years, and then IVIG as a source of treatment for the myositis, dermatomyositis, polymyositis, is that considered a long-term treatment for dermatomyositis, for myositis?
IVIG is a great long-term treatment for dermatomyositis, polymyositis. Yes. But the thing is, most patients don't want to keep getting infusions. So what we recommend, at least I recommend, is we get infusion for a year, maybe 2 years, and then see if we can cut down the infusions. So normally somebody's getting, let's say, 2 grams per kilogram infusion every month. Once they're in the remission, and they've gone 6 months into the remission, 3 months into the remission, I am very confident about the disease gone into remission. I say let's cut down the dose to 1 milligram per kilogram. Okay, let's see for next 3 months how your body do. Because IVIG is only lasting in your body for about a month. So you will get to know if there tends to be a flare-up, right? In a month, it's gone. So let's say in that case, I will do every month 1 milligram per kilogram. 3 months gone by, maybe 6 months gone by, patient is doing rock stable, doing great. All right, let's cut it down to every other month. We'll get to know. Let's cut it down to every other month. In the meantime, since I'm taking one drug off, I may want to introduce some other drug for a maintenance treatment. So I go to every other month and maybe add Immunosuppression a little bit as a baseline drug, okay? Then every 2 months gone by 3 times and the patient is still doing great. Then maybe you don't need it at all. Maybe we can go to every 3 months, couple of times and get off of it. So a lot of patients are able to get off of it. There are patients who will come and tell me, Doc, I was fine for a month, but the next month, when you put me on every other month, was a rough month for me. Once I got the infusion, I got better again. That's a very strong statement from a patient, okay? And most doctors will go for that. Most doctors will understand what's happening. Basically, the disease is not gone into the remission, it's gone under control with the treatment, so they are in remission on treatment. And there are many patients who stay in remission on treatment. So that means they need on treatment. Now what happens, that kind of patient, I would continue their IVIG, let's say, or any other drug. I mean, IVIG is one example, but any other drug for another 6 months or a year, because they've shown that they had this flare-up or tendency of flare-up. Then I will go for a year. In a year, your immune system has changed to some extent. You might be feeling great right now, and it's been gone a year that you've been feeling great, and your body has changed. You haven't changed. But the immune system has changed, and immune system is causing the problem. So why don't we give it a benefit of doubt again? And let's try it again, let's try to cut it down slowly and see if your body is able to sustain it. And many patients, I sometimes take 2 or 3 or 4 tries to get them off. Some people are able to get off in the first try. Everybody is different, everybody's immune system is different. The basic concept is once your disease is stable for long enough, you can experiment again. So 6 to 12 months is long enough time on a drug where you feel, okay, I've been in remission on treatment for 6 to 12 months. I would like to see if I can cut it down. If I fail, again another 6 to 12 months, I can try again. Now obviously if you try 3 or 4 times, you kind of give up because every time it's not working out. that's a different story. But it has happened to me that I've tried for 3 consecutive years, and 4th year, boom, they got off all the treatment eventually, you know. So it can happen because the immune system is we don't understand it very well, and it's constantly changing. It's like a very fast rate of changing in most patients. The immune cells are all constantly coming. New immune cells are coming, old immune cells are going away. There's some memory formation and stuff like that. So, okay.
Thank you.
Can you comment on Cytoxan and how that could possibly, I guess I was reading it could increase the risk for cancer?
Excellent. Yeah. So if you get Cytoxan treatment, that means you had a bad myositis, okay? Either you had a very bad myositis or you had a very bad complication from myositis called interstitial lung disease. Those are generally 2 reasons that we give somebody Cytoxan. Or you could have gotten Cytoxan for cancer treatment, okay? Because Cytoxan is a treatment also given for cancer. In any of the circumstances, if you've gotten Cytoxan, there are 2 cancers you need to worry about.
Sorry, can I ask you, what is Cytoxan?
Cytoxan is cyclophosphamide. It's a very toxic drug that is given for severe myositis and patients with a severe interstitial lung disease or pulmonary fibrosis. Those who have bad lung disease with myositis, or those who have very, very bad myositis. Those are 2 reasons. Generally, it's not a very common drug that we use in myositis.
And what group would that be? Like methotrexate, or would it be like a steroid, or would it be like
it'll be methotrexate group, but think about methotrexate on steroids.
Okay.
So it just seems kind of odd to me because we were told that it's a chemo drug to treat, you know, like you were saying, severe cases of myositis, but at the same time, I'm reading that it can increase your risk of cancer.
Yes.
So it seems...
It's called, there are many drugs that do that. So they're used to treat something, but the same drug can cause the cancer as well. So Cytoxan or cyclophosphamide is highly associated with future risk of bladder cancer and blood cancers. Those are 2 cancers that you can happen. But it is very dose dependent. So if you give Cytoxan in lower doses, the cancer risk is not that high. But if you've gotten Cytoxan in a much higher doses for too long a time period, then you have to continue screening for bladder cancer and blood cancer. Those are 2 common cancers. It happens 5 to 10 years after that. I mean, it doesn't happen right away. The Cytoxan doesn't cause this cancer right away. If you receive Cytoxan, cyclophosphamide, higher doses for long enough, maybe a year or 2 years, and higher doses, maybe total dose that you've received is 10-20 grams over the period of time, then you've got to be worried about future risk of cancer in 5 to 10 years. So it doesn't happen right away. And what I recommend is somebody's gotten high doses of Cytoxan, their doctor should do urine cytology every year.
Do what?
Urine cytology. It's a test of urine. In urine, they look for any cancer cells for bladder cancer. Because the bladder cancer cells will go in urine, so you can spin the urine and see if there's any cells, cancer cells every year. And then the other thing I tell them is to do the CBC, the blood count testing every 6 months every year. So those are 2 things I recommend if somebody's gotten high doses of cyclophosphamide.
Thank you.
If a patient is TIP1 positive and they don't have access to their family history for being adopted, should they do further blood tests, as in the CA-125?
Absolutely. So if you're TIP1 positive, or if you'll come to me, you're going to get PET scans, see cancer biomarkers, pap smear, mammogram, colonoscopies, you name it, I will do it. You know, because what I'm worried about is your risk of cancer is much higher. So why do I take any chance? Let me just do all the tests and make sure you don't have cancer. But in younger patients, what we're finding is there is less cancer with TIP1 gamma itself. So I'm less worried about younger patients. So, but if somebody above 15 years comes to me, they're getting every test I can do to screen for the cancer.
In DM, are you seeing higher cases of vaginal Crohn's? And then if so, are you seeing
Vaginal what?
Vaginal Crohn's.
Crohn's
disease in the vagina.
Crohn's disease, huh?
Is a higher relationship with DM?
No, I've not seen that.
You haven't seen that.
No, I've not seen it. Remember one thing, any autoimmune disease, and it's true for myositis as well, But when you have an autoimmune disease, your risk of developing another autoimmune disease is higher. Okay, that you should understand because genes of autoimmune disease are related. So the fact that you develop one autoimmune disease, you can have slightly higher risk of developing another autoimmune disease. Another question that I get asked very commonly is if I have myositis, would my daughter or son or someone else can develop myositis? Again, the same logic applies. Your daughter or son is at higher risk of developing an autoimmune disease. Does not necessarily mean myositis. In fact, I only have one patient-daughter pair of dermatomyositis. So, but I have many people who have dermatomyositis and their daughter has some other autoimmune disease. Do you see what I'm saying? So the autoimmunity generally go together does not necessarily mean myositis. In fact, I would say the patient that comes to me and says, oh, I was dermatomyositis and my daughter is having muscle pain and muscle weakness, I would suspect that it's not the myositis. Because generally the same disease doesn't go together that well. As I said, only one case I know that was true.
So what kind of screening would you give daughter, like your daughter, maybe like an ANA test?
Okay, that's a great question. So when I'm saying they're a higher risk of autoimmune disease, what does that really mean? Higher risk is a very vague term, so let me explain that a little bit, okay? So let's say I have dermatomyositis, okay? And I'm worried about my daughter to develop dermatomyositis or any other autoimmune disease. So what can I do to look for it, right? That's probably the most important question that I get. You don't need to do anything, and I'll explain you why. Because risk of somebody in general population to develop autoimmune disease, let's say, or dermatomyositis, let's say if that risk is 1 in 100 in a general population. When I say your daughter or son is at higher risk of dermatomyositis or other autoimmune disease, I mean 3 out of 10, 3 out of 100. So the risk is a lot higher, means it's 3 times higher risk, right? Okay? But 97% chances he or she is not going to develop it. So you have to understand when we say risk, what does that mean? So would I subject somebody on a constant screening and fear for 3% risk in life as compared to 97% risk they're not going to develop it? Right? So what I'm going to do, I'm going to look for symptoms. If he or she develops any symptom, I'm not going to ignore it. That's the best advice I will tell you. Look for symptom and don't ignore it. You know, go to the doctor, maybe, and most times if they have symptoms, they will be something else rather than the autoimmune disease. But that way you can be a little bit more vigilant rather than ignoring symptoms of your son or daughter or something. So most cases will not have any problem, but they are at a higher risk than general population.
So you wouldn't even do an ANA test and just see if it's positive?
No, I would not do it.
I came down with dermatomyositis last July. A year prior to that, our daughter was having some symptoms, went to the doctor, and they thought, oh, you might have a connective tissue disease. She took prednisone, and the problem went away, so end of discussion on that one. She's now having other aches and pains. And I'm just wondering, is there a possibility of a connection?
Yes, she may have rheumatoid arthritis, let's say. I mean, I'm not saying she should, but what I'm saying is that doesn't mean she would have dermatomyositis. All it means is you should go back to your doctor. And another autoimmune disease is within the realm of possibility, yes.
So what are your top drugs that you feel should be prescribed for DM that would lessen the chance of cancer, since we're talking about
there is no treatment that lessens the chance of cancer, okay? What I would say is effective treatment lessens the chances of cancer. Means basically if whatever treatment their doctor may give you, and if you are able to get into remission or low disease state, that's the best remedy for developing any future problems. No, not a particular treatment per se, that this treatment has been seen with higher cancer or less cancer. That's not true.
What I'm saying is I'm on methotrexate and I'm pretty well tolerated. Is there another drug that you could try? You know what I'm saying? You said it.
Why would you go to another drug if you're doing well on methotrexate?
I just thought the cancer risk.
No, the cancer risk, okay, so let me explain that to you a little bit. That's a very good discussion. So people think that they read different things, everybody reads different stuff, and they think that methotrexate has high risk of cancer. That is absolutely not true. In one way, and it's true in another way. I'll explain you. All immune suppressive drugs, except for IVIG, is not an immune suppressive drug, okay? But all other drugs that we know for myositis are immune suppressive. Celsep, azathioprine, methotrexate, rituximab, all of these drugs are immune suppressive drugs, okay? When you suppress the immune system, what happens is the cancer surveillance of your body goes down because your immune system keeps your cancer cells to some extent under check, okay? So any immune suppressive drug, you are a little bit higher risk for cancer. That is true for methotrexate, that is true for sulfur, that is true for azathioprine. It may not be that well known for, let's say, azathioprine, and it's more well known for methotrexate because methotrexate has been the most studied drug. But that should scare you from not taking methotrexate. Does that make sense? Because if you had to take other than methotrexate Immuran, you're exposing yourself to the same risk, per se. So it's no benefit if you're doing good to stay on the drug, or maybe lower the dose if you're doing good for a while. But changing drug because methotrexate has been known to link with cancer, all of these drugs have been known to link to cancer with different capacity. It's just the information available to us is a different information. Okay, yes.
In your practice, what's the recurrence of these cancers?
So if the disease is well controlled, I would say I have seen recurrences even like 10 years out, to be honest, but it's rare. Rare. I mean, I can remember 3 or 4 or 5 cases where the cancer came back after effective treatment, but that's pretty much it. So it's not common. The people who get into trouble are the people who get better and stop treatment.
Is it the same type of cancer?
It could be same or it could be different type of cancer.
Well, wouldn't that be the same for anyone else? So let's say we don't have DM, I mean, that's the same problem.
It's just that you're a high, exactly. It's just that you're a high risk. That's the only difference. A little bit more frequent. For example, I had a patient who had lymphoma, well treated, 10 years, and she's off treatment and doing great, and she developed new lymphoma. And so generally I've seen the same kind of cancer more commonly. Breast cancer I've seen come back again in a different breast or different, but not, I'm talking about number of patients I can count on my fingers that has happened. So it's rare, but effective. The patients who get into trouble are patients who stop treatment because they're feeling good. Feeling good is a good thing, but don't try to rush to get off medication. That's a very common mistake most patients do. And I'll give you another example of a patient who came on a wheelchair, very bad anti-SRP antibody positive patient with severe muscle disease. Patient got into remission. Within like, I think 9 months or 10 months, he's doing everything he can do. He stopped coming. Young patients, that's a major problem. They stop coming when they're feeling good. Stop the drugs, stop coming, and now he came back after 1.5 years. Bad disease, now tried so many different drugs, he can't get all the way back up. And that's a common problem. Once the disease flare up, especially if it was due to premature stopping of the medication, when it comes back with vengeance.
And that's exactly what happened was, when I went into surgery, they had me stop the surgery. I consulted with the rheumatologist and said, I want her to stop the medication. Because the cell set was on 25 milligrams. And it was for a month, and I did surgery, and I was recovering from surgery, and I was like, something's not right. Yeah. And quite honestly, I mean, my CK levels weren't even as high as my first time. Yeah. And I was in really bad shape. I was bedridden.
Yeah, so that's another common mistake. The surgeons, well, first of all, they don't have that much of medicine training, right? So they want to minimize the risk of this surgery, okay? And for that reason, any medication on board, especially immunosuppressive medication on board, you're going to have high risk of infection during surgery. So what they prefer is for you to get off medication, but that is not a good situation. In your case, for example, what I would have done is I would have talked to the surgeon, maybe taken you off of Celsep for 2 weeks, okay? during pre and post surgery, and maybe corticosteroid dose to less than about 10 milligrams.
Which it was. It was less than 10 when I went in, but
Did it not go up in a week after surgery? If the surgery was successful in a week?
No, they told me to wait 2 weeks afterwards before I started my medication again. But by then I was already a month.
Yeah, month
with
gone.
no medication.
Yeah, generally my general rule of thumb is stay within a month. If you stay within a month, these drugs are still effective. Most of our drugs are still effective within a month's time frame. Most patients flare up at a month, 2 month, 3 month time point. So I don't let them go beyond a month off these medications for whatever reason if they had to be stopped. So
but that was a conversation that, I guess my frustration with that is that the rheumatologist.
But your rheumatologist is not a myositis expert, right? I mean, that's what I'm trying to explain. You their training and their knowledge is limited to the extent that, I mean, it's not that your doctor is not a good doctor. It's just that in the world you can't know everything. And that's the problem or challenge we have.
It's a very rare disease.
It's a rare disease, so you're not going to learn a lot about it during your training. Alright, so maybe we can switch gears and go to another topic. Perhaps we can talk about, so since the topic is cancer-resistant myositis, we talked about treatment. We talked about the risk factors, you know how the disease is diagnosed. What other questions can we try to answer? Yes?
Can you talk more about why effective treatment for myositis is the best way to stave off cancer exciting like that?
No, so what I mean is it's what we don't know if is cancer to myositis is a one-way street or is a two-way street. Okay? So that means is it always that the cancer leads to increased myositis and dermatomyositis, or there's a feedback that is a constant inflammation may actually lead to cancer? That's the reason I tell that effective treatment is your best way of preventing, hopefully, future cancer, because there's nothing else you can do. So if you have an effective treatment for urine inflammation, that means that constant inflammation has been known to as a risk for cancer. Okay? It's been very well known as a risk of cancer. Constant inflammation, constant irritation are the common risk of cancer. So that's why I tell people to getting disease under control is probably the best thing we can do to prevent the cancer risk or prevent the cancer. But there's no one-to-one direct link that I know.
I'm on platinum because of my skin itching. So it hasn't helped yet. But being here, I don't itch as much. Of course, I'm not in the sun for 3 days. So that could be it. But how long does it take for platinum to finally take effect?
2 to 3 months.
2 to 3 months. And there's air conditioning circulating all the time. Does that have something to do with the itching going away?
Otherwise, your disease is under control?
So, I still have some weakness. I had lots of itching until this weekend.
Yeah, so, but no rash.
Oh, yeah.
So you have rash as well. So basically what you're saying is your disease is not completely controlled. So the first answer would be to control the disease. There still may be residual itching. There still may be residual rash that leaves. There still may be residual weakness even after your disease is completely controlled. But that's a different problem. The first thing is to get the disease under control. If the disease is not under control, rest everything is not going to be useful. So for example, a patient with dermatomyositis, I treat them and the disease is gone into remission. They have just a minimal redness or some minimal skin changes. Those are going to remain. I'm not going to worry about that. Why? Because the skin has developed some damage over time. And what happens is that damage has led to increased vascularization of the skin. So that little bit of redness that is not bothering my patient and is not active disease, I'm not going to worry about it. Because that's going to stay. Because if I try to treat that, I'm going to be using a lot of toxic drugs without much benefit. Because there's some damage that will happen.
What does that mean? What do you mean when you say vascularization of the skin?
What happens is the constant damage, the skin changes, causes some damage, and then increased blood supply in that area that can cause some redness.
Increase
blood supply that can cause some redness. I'm not going to worry about that. I'm not going to. If you are in a minimal disease state, low disease state, inactive disease remission, You don't need to worry about now. For example, polymyositis. Many patients will tell me, look, I am much better than what I was. I'm 95% better, but I'm not 100%. Okay. Then my question to them is, okay, that means basically the question for me is, should I change your treatment? Should I try to do something more? Well, then I ask them, how are you doing your daily activities? Do you have any limitations in your daily activities? Whatever you want to do, hiking, are you able to do hiking? If you want to do just, regular walks, are you able to do regular walks? And if the answer comes back, I have no limitation in my day-to-day life, then I say, don't worry about the 5%, because that might just be muscle damage that I may never be able to recover, and I will subject you to toxic medication, try to recover the 5%. If you wanted to do it, I will do it, but that's not a logical thing to do. It's not a rational thing to do. And there are other parameters that I can tell you or reassure you your disease is not active. And that generally helps to finish the conversation, because when the patient's expectation is that they're going to get 100% better, they end up doing more damage or more harm to themselves than not.
No, so I'm on a lot of drugs too, but I have a lot of energy, so I can do exercise and all that. But I cannot do some specific motion. So if I try to sweep the floor, that gets me exhausted. If I try to clean a mirror, for example, that's like some specific motions will get me exhausted. I can do other things. I can run. I can,
So most likely you don't have a problem.
No.
So that could be a damage to a particular muscle areas, and that means I would not go after that.
Okay.
That just tell me you can try to recover it with exercise, because the only thing that can improve damage is exercise. Okay, that's the only thing that can recover damage. But I would not try to, because what you told me, I'm pretty sure you don't have active disease, because you're able to do most of those activities. Because if you had active disease, you won't be able to do that. Yes.
I just want to piggyback on something you said a little earlier. I know when I visit my rheumatologist, he'll give me a contact sheet, and I'll have a whole range of diseases on. I'm going to check off the 1 out of 5 today. And I'm saying, I said, that's a lot of diseases for a rheumatologist to be knowledgeable about.
Yes.
And what you were saying is that in a doctor's practice career, maybe you only see a few patients or deal with a few of those diseases.
Yeah.
And I just thought that was
significant. No, so the thing is, but there are things that are common. So for example, in my training, every day I would have seen at least one patient with rheumatoid arthritis. Every day. Now if you see that every day of your training for 2 to 3 years, you know that disease very well, right? But I may have seen a dermatomyositis maybe every 2-3 months. So in 2 years, I may have seen 10 cases. That's not enough to get your head around it.
Right.
So that's what I was trying to explain. But there are certain centers that are more for, so the centers which are where they're experts in dermatomyositis and polymyositis, the trainees who are coming out of those centers are going to be much more trained in those diseases, because there are more patients coming to those centers. It's just about what you've seen or not.
In getting at with interstitial lung disease, is there any type of reaction between CellCept and Aggarwal?
I do Plaquenil and CellCept all the time together. I have not seen any problems. Although I must say that Plaquenil is a tricky drug in dermatomyositis, because I have seen, and it's been reported in the literature, that it can paradoxically cause more rashes and flare-up of dermatomyositis in few cases. Would that deter me from not? So does that mean that I should not use Plaquenil? No, that doesn't mean anything, because it means that many patients it does help. There's a minority number of patients actually can go to paradoxical effect. That's something to know.
Thank you.
Do you see for patients that have DM, do they have a like a chronically low IG panel if you were to test it before doing IVIG treatment?
So the question is, do I do IgG panel before doing IVIG treatment? I do that, but the reason I do that is for IgA and not IgG, because it doesn't. If the IgG levels are low or low on the lower side, that doesn't tell me the effectiveness of the treatment. I've had patients who have had normal IgG level, and when I give them IVIG, it improves. I mean, their disease improves. And that doesn't have it. The reason I do is IgA. If you have an IgA deficiency, then you have to be worried about giving IVIG, because it can cause some reaction.
I'm sorry, if
Okay.
IgA is what?
IgA deficiency, if you are deficient on IgA, most doctors will check your IgA levels before they give you IVIG. Because if you don't have a IgA in your body, and if I give IVIG, which may have some IgA as well, your body may react because your body has never seen IgA still. Yes. All right.
The pathologist who was able to diagnose me happened to be the one he also said that I would be platinum for the rest of my life. And then the other thing is the local dermatologist melanoma said, of course I got red all over the body, but your body's getting darker. I'm a brunette today, and he says, platinum can actually
Yes, that is true. 5 to 10 years of platinum, post 5 to 10 years of platinum, there is some pigmentation from platinum that can happen, can lead to skin darkening. That is true.
Would that be why I can't get rid of the mask? I mean, I have all of this, all of this, all of that.
How many years have you? How many years have you taken platinum?
Actually, 6 months.
Yes, that doesn't.
Or is that from the chemo?
Not from platinum. That's probably from chemo.
Platinum also has issues with your eyes.
So it's that's a very good question. I'm glad you asked that. So first of all, let me ask myself this question: how many times in my 10 years of giving platinum have I seen platinum causing eye blindness? Any guesses?
One. Color blindness,
Color blindness 0.
retinal detachment,
0.
really.
Yeah, okay,
And
so-
you say it's a high risk though.
Yes, okay, I'll explain it, okay? The reason for that is, in past, in 1990s, we used to give platinum at much higher doses, and at those doses, there is a significant high risk, okay? And what we figured out since then is, if you keep the platinum dose less than 6 to 6.5 milligram per kilogram, which generally means 300 to 400 milligram for an average person. If it's a smaller, tinier person, then maybe 300 milligram. If you keep the dose at that or less than that, the risk of eye toxicity drops down pretty quickly. Okay. Then, even with that risk, so even then the risk is 1 in 1,000. Okay? Even if you give a right dose, there is still risk. Okay. Now let me explain to you. If I tell the patient that do your eye testing every year, how is that risk affected? It goes to 0. Why? Because eye toxicity is not like this. Eye toxicity develops over years. So if somebody is getting eye checkup for platinum every year, it is likely that your ophthalmologist will detect those changes much before you get any problem. And once they detect those changes, they will stop the platinum and you will have no problem. So how many times I've had where ophthalmologists call me and say, hey, I see some changes. About 7 or 8 times. So it does happen, but none of those patients got into any trouble. So it's actually a foolproof drug if, only if, you're taking the right doses, don't have other eye problems or risk factors of eyes, and you're doing eye monitoring. So I feel that a lot of noise is there about platinum, but in reality, we haven't had much problem with platinum.
So when the doctor does know this, and you go on
Then you're okay.
I've been platinum for 4 years now, and I didn't tell myself he decided to change from platinum to chloroquine, and my it just seemed like I couldn't take that for eye problem.
I have never heard of this, that somebody is doing well on platinum and you would change to chloroquine. That doesn't make sense. I'm not sure why. There must be other reasons that I'm missing.
Well, he's trying to treat my hair longer.
Yeah, so there must be some reason that he's trying to go to a different drug to treat. Now that's, but chloroquine has high risk of eye toxicity.
So then, but then basically what he said now that they help they provide for the rest.
Yeah, so if you do eye checkup every 6 months, you're fine.
Yeah, so I'm gonna see my doctor, my eye doctor.
And every 6 months thereafter. And keep the dose, if I remember it correctly, the dose has to be less than 3.5 milligram per kilogram. if you drink it.
Have you seen eye problems with any of the other sulfate or prednisone?
Steroids, yes. Remember, steroid is a major problem. Steroid causes glaucoma, causes cataract, causes all sort of, patients with intermittent blurriness. It has all sort of different. Yeah, steroid is.
I must ask that it's time to adjourn. Yeah.
Thank you.
Evaluation.
My name is Chris Harris. I have dermatomyositis. I was first diagnosed in 2005. So this is my 12th year, and this is my first year to this meeting, which I'm kicking myself for, but going forward I'll be at every one. My favorite part of this meeting is meeting the patients and their advocates, and I'm amazed at the support that I've received since I've been here from everybody. And I love that people have shared their stories, no matter how challenging, but I love the idea of hope for everybody. And my second favorite part of this meeting is the individuals who have donated their time to move this disease forward and try to find a cure, which includes everybody with the Myositis Foundation as well as the panel. Every person who has volunteered their time, the physicians, the physical therapists, the volunteers, and the fact that they've committed to do this as they move forward is amazing to me. And I love it, and I will be here again next year and the year after that. And it just gives me a lot of hope when I was very depressed. So thank you for inviting us, thank you for supporting it, and I look forward to seeing everybody next year.
Hello, my name is Anastasia Victorson, and I came here all the way from Stockholm, Sweden. I'm very happy to be here.
Is this your first time coming to the Myositis?
To this conference, yes. To the TMA conference the first time.
What's it been like?
It's been fantastic. Very informative. I've met my friends, my Facebook friends, and I hope I'll be able to come again. I have polymyositis, but I also have a syndrome that's called the Antisynthetase syndrome. I have antibodies, a lot of them, but anti-Jo1 is the most common one. And I also have ILD, quite serious. But getting medication, feeling quite okay. The doctor saved my life. Yeah, very good information. And it's also nice to see the persons. I read a lot. It's also nice to see them in real life, to be able to interact with the doctors. Yes, I'm just happy to be here, having met you too. Take care. And everybody else that hasn't been here, hasn't gotten a chance, please try, because this was really worth it. It's beyond my expectations, really. Thank you.
Hello, my name is Dale Scott. I'm from Pennsylvania, and I'm looking for all the people from Pennsylvania for our kit group, so give me a call.